I would like to provide you with some data on treatment. As you heard, all patients, with the exception of one who's seizure-free, are taking AEDs. And if we look at this majority of patients over the age of 14 and who are seizure-free, i.e. 70%, they still are taking polytherapy. And this is another important element. Another interesting finding is that subjects with early onset for the age of 6 months are all on a polytherapy, which indicates that the outcome is less favorable, whereas patients with monotherapy are only those with a later onset of seizures. If we analyze the entire population, we can see that the most commonly used AEDs are valproate, carbamazepine or oxcarbazepine. It's a slash, actually, not a plus that you should see here. And benzodiazepines in some cases. Whereas, as you can observe, other AEDs such as PHT, RFM are less frequently used. Now, if we look at the population breaking down between those who still have seizures, we can see that there are only a few patients, 5, who, despite persistent seizures, continue to be on monotherapy. 3 valproic acid, 1 levetiracetam, and 1 thyropyramate. Whereas mono or poly, or rather, says the speaker, the most represented polytherapies are VPA, carbamazepine, clobazam. Some patients are on combination therapy with STP or other minor drugs. With respect to subjects with monotherapy who are seizure-free, or while seizure-free are on monotherapy, we see that we have in all 8 patients, that is 35%, and they take VPA, CBZ, and LEV, whereas seizure-free poly patients are on carbamazepine, levetiracetam, and a number of other drugs, as you can see. Phenytoin and others are actually absent in this population. So what we've tried to do is the following. We have tried to attempt to correlate and compare the two groups, seizure-free versus seizure-persistent patients, comparing the percentages of drugs used. In the seizure-free group, 60% take CBZ OXC. LEV is represented significantly, and while we have a small group of patients, STP is nonetheless able to give a significant response. So, the preliminary conclusion that we've drawn, bearing in mind that we only have a small series, is that these drugs would appear to play some role, and therefore they can appear to be more effective. Now, if we look at response in seizure-free patients, we need to also look at the cognitive outcome. Patients who are seizure-free in 17.6% have normal IQ. 14% have borderline or mild impairment. 39% are affected by moderate to severe ID. At this point, If we look at the situation, breaking down patients by different age groups, patients who are seizure-free above the age of 14 have a normal IQ in only 12.5% of cases. So there's a drop, whereas there's an increase in the number of those with a more significant impairment. And this confirms what we had initially observed clinically. We have a series of patients from Verona, and we try to determine cognitive outcome. This is developmental quotient over the years, and here we see that at the moment of onset, cognitive functioning and development vary significantly, with impairment at our onset in many cases, even though most patients are in a normal condition or have mild impairment. But in some cases, as you can see, there is a decrease in cognitive and neuropsychological performance in some cases, whereas, surprisingly or not, there are some patients who start off with a good cognitive level and preserve it. As you can see, there is a substantial difference with respect to patients with Dravet syndrome. They all have a normal, say, profile in terms of cognitive function, but in a few years, after the age of 3 in particular, the decline is considerable and significant. And almost all, in practice, with no exception, present severe cognitive impairment. This said, there's another interesting finding which we observed in examining the registry. This is the age of onset and the time from diagnosis, median values. The quickest, let's say, diagnosis occurred in subjects for whom onset occurred around 2 years of age. So when onset occurs in the second year of life, diagnosis occurs earlier. It's quicker. What does this mean? Is it a bias dependent on registry data? Or is it possible that with febrile and cluster seizures, it is easier to arrive at a diagnosis? We know that in the first year of life, it's hard to interpret the conditions because we see focal seizures, febrile seizures, cluster seizures, so it might be harder to recognize that condition. So we have seen that the register can provide interesting data. Early outset appears to be associated with behavioral disorders and a less favorable outcome in general. This is something that was also shown by the previous presenters. One can assume that early onset is a prognostic factor, and also it can account for the fact that evolution is so variable. So the assumption that early onset at a neuronal level ultimately jeopardize development is certainly an interesting assumption. We also analyze data from the registry, and we have seen that there can be two different populations. In fact, not all subjects with PCDH19 have the same picture. There are some for whom onset occurs below the age of 6 months, and then we see pharmacoresistance, persistent seizures, and onset of severe behavioral cognitive psychiatric disorders, whereas there are some patients for whom onset occurs later, and they are less likely to develop. Significant impairments, and generally they are more likely to have a better picture as far as epilepsy is concerned. And finally, we have seen that disease register is certainly a very useful tool to derive clinical data and obtain indications on the real picture and what these patients' conditions truly are. Longitudinal data from a number of patients can help us understand what their status is in the long term and what are the factors that can make a difference in terms of development, in terms of treatment. That is all from me. And of course, I am happy to answer any questions you may have.